Joe, I started the cloud recording, so one more admonition against cursing.
Okay.
It's 4 o'clock, Joe. I muted you, buddy. You were ripping paper or something. Oh. Oh, you're muted there, Joe.
We have, see, 29 out of 139. Do you want to wait a couple of minutes?
Nope. I think we should not punish those attending promptly.
Okay.
In favor of those tardy. Welcome, everyone. My name's Tom Bartholomew. Let me turn on my camera. And you can see behind me, I'm in Santa's workshop. And today we have my colleague, Joe Berkman, who's going to be manning the chats because for me, it's like patting my head and rubbing my belly. I just can't do it. And we're going to be talking about best practices in clinical supervision. And I can pretty much guarantee all of you that this will be the best presentation that you have seen today, unless, of course, you've seen another presentation, in which case all bets are off. I can't really promise anything. But this information, Joe and I have been working on this for many years, and it has benefited me tremendously. And so far, we've been presenting it for quite a while, and people seem to get a lot out of it. So I hope you do as well. So this training series, in essence, we're going to do topics 1 and 2 today, and then next week at the same time on Monday, we're going to do topics 3 and 4. And they are usually they're presented separately, but they don't have to be, of course. And so there'll be a little overlap and a little redundancy, but I don't think it'll hurt you. All right, I'm going to turn my camera off. I have that problem that Narcissus had where, he was so affected by his own beauty that he stared into a pond and died. All right, so these are the objectives for this topic 1. And the first one, we're going to be talking about this thing called reference standards. And I'm going to encourage you guys to learn at least 3 of these for the work that you do. And I'll give you a little exercise. We'll do an exercise where you can identify them. They're different for every practice, for every type of intervention or permanent supported housing or whatever you're doing, drug and alcohol work. Next, we'll be covering what are the generic functions of clinical supervision. And it's been our experience that virtually all models, I think all models of clinical supervision, address these three generic functions. And in that way, you can think of clinical supervision as having these three functions, or you might call them objectives. And you can focus on that instead of the huge number of clinical supervision models out there. There were 200 in the 80s, and I assume now they're 2 or 3, 4 times that. And if you can stay awake, of course, I wouldn't know because I can't see you, but that would be one of my goals as well. So after the second session on Monday next week, I'll send these materials that are here on your screen and to Castle, Kimberly Castle, and she forwards them ahead to anyone that signed up. And so as we proceed, you'll hear me reference some of these things, and just be assured that they're coming to you. The first one, which we won't talk a lot about, but is a clinical supervision fidelity scale that Joe and I developed. And we welcome you to use that if you're interested, even just to check it out, read over it. But it really is the outline of much of what I'll be presenting. There's also a contract on that same document, a kind of a generic clinical supervision contract, which you're welcome to use. I stole it from someone, you're welcome to steal it from me. And then 2 through 6 are ways to measure various aspects of the impact of clinical supervision on your organization, on burnout, things like that. And then lastly, there's a generic agenda you might use for clinical supervision. So all these things are coming. You'll hear me talk about them as we go. All right, so the first issue that you realize when you start talking to people about clinical supervision is they often confuse clinical supervision with administrative supervision. And here's a definition of administrative supervision. And so it's the idea of policies and procedures, attendance, paperwork, a focus on good standards of work, coordination of practice, assuring that the office is smooth and efficient, and so time, attendance, documentation, and logistics. All of these things are obviously critically important. If somebody doesn't show up for a session, you can't expect to have any kind of outcomes for that session. You can't even have a session with someone or a meeting with someone. So we're not saying that administrative issues aren't important, but it is not the focus of clinical supervision. And we'll get to a definition of clinical supervision in just a bit. So my first pro tip for you guys, as somebody who's been doing clinical supervision for almost 30 years, even though I'm quite young, is you may want to bump up important administrative issues to your leadership and not dwell on them in clinical supervision. We found that one problem in clinical supervision is we get stuck on administrative issues and miss out on the opportunity to really talk about the clinical part, which is the interface between clients and staff. So that's pro tip number 1. I'll be on the quiz. All right. So I realize after presenting this information many times that people often think of 2 different types of supervision, and Joe and I are really experts in the second type. But you may have heard of developmental supervision or developmental clinical supervision. And that is the process of helping somebody become a professional. Generally, oftentimes they're entering the field and they need to learn the ropes, frankly, right? And so that's one type of supervision that's referred to quite a bit in the literature. Joe and I have an expertise in what's called intervention-specific supervision. So that's if you're doing a particular practice and you want to look at fidelity and treatment adherence standards, things like that. That's a little bit different, but what you'll find today is there's really way more overlaps than differences, frankly, because many things that you need to do in either of these supervisions are very similar.
And kind of the issue is some people don't do either.
Right. That's a really good point. Yes. So if nothing else, these presentations will get you thinking about, hopefully get you thinking about what you're doing in clinical supervision if you're currently providing it, or if you're about to provide it, give you a bit of a map. All right. So for many years, I taught a class called Clinical Principles in Psychiatric Rehabilitation. And I'm a bit ashamed to acknowledge I didn't know what the word clinical meant, despite teaching a class with it in the title. And so if you would, use your chat, shake off your chat, clean off your chat button, and put down what you think the word clinical means. What does the word clinical mean? Clinical. Right?
Someone had a question, Tom, about CEUs. Unfortunately, at this point in time, we can't offer CEUs.
No, and that would be up to your leadership, Kimberly Castle. They could set that up. That wouldn't come. I mean, we're certainly prepared to provide it in a CEU.
And my understanding is they're working on it.
Oh, okay, great. Did anybody crack the case? What does clinical mean?
Okay, let's look. Oh, okay. Evidence-based, broad scope of practice.
Nice.
A deeper dive, examining the why or what is going on.
Nice.
Thinking of it as someone who is licensed. Big
Okay.
issue today. Observation and treatment, what we sometimes think about as audit and feedback. Working with real humans rather than just theories. Discussions related to observation and details related to clients. Relating to the observation and treatment of patients.
Nice. Well,
Yeah.
you guys could work for a dictionary with that kind of. All right, so I looked it up, and it's more. There's more definitions than this, but for our purposes, I liked applying objective or standardized methods to the description, evaluation, and modification of human behavior. A little wonky, a little academic, but it does speak to the idea that when you go to school, you learn kind of the science of mental health treatment, and when you apply that in your mental health work, that to me, you're in the sphere of clinical intervention. So it's not just winging it. It's not just walking in and doing whatever you feel like at the time, but there really is, there are objective and standardized methods that we can pull on. So what does that mean, objective and standardized methods? Joe and I like the term reference standards, referring to what are you supervising to? So if you're going to do clinical supervision and you're going to try to address the objective and standardized methods, what are the things that we're comparing to? So what is a better intervention compared to a less good intervention? And can we even do that in this field, or is it like still the Wild West? Other terms for this are programmatic fidelity, treatment adherence standards, and I don't know if you've ever heard of the term common factors, but I'll be talking about that in just a bit. So this is pretty important if you're going to be a supervisor, that you have a sense of what the reference standards are that you're supervising toward. And it's true also for administrative supervision. So you have to know what the standards are for documentation, the standards for attendance, the standards for ethics, and that kind of thing. So this gets a bit wonky, but bear with me. So in the literature, you'll find this idea that you can kind of reverse engineer what it is we do and put them into these various categories. And I have a triangle that makes this a lot easier to understand, which I'll get to in just a second. But like you think about the behaviors of the people we're supervising as well as our own behaviors, and you'll find that there are behaviors that are essential but not unique, behaviors that are compatible with what we're doing, but they may not be necessary, behaviors that are unique and essential to the model, and behaviors that are prohibited. And let's just look here. So if you start at the bottom of this pyramid and you say, what's compatible with what we do, but not necessary or unique? So it's not necessary that we do it. And so can you give us some ideas in the work you do? What's something that's compatible with your work, but not necessary or unique? Say when you're interacting with a client, what are some things that are compatible, but neither necessary nor unique? You see where we're going with this. I'm going to ask you each one, right? So I imagine, I could go out for coffee with someone if we weren't in a global pandemic. But we could talk about our families. We could share with one another.
Asking how their day is going.
Nice, absolutely.
There's one.
Not necessary, not unique. Nor is it unique to the work we do. Anybody could do that, right? It's not unique to personal supported or supported housing or vocational work. All right, let's keep going. Let's look at B. So what about small talk? Very good. Talk about the weather. Yep, find common interests, right? Let's look at B. What is essential to what we do, but not unique to what we do? Oh, I even gave you some clues there. So you might even argue that, I don't know, is small talk, is that essential? Maybe not. But what is essential?
To be non-judgmental.
Nice.
To be present.
Nice.
And to paraphrase, etc.
Nice.
Discussing, be able to discuss goals.
Yeah. Yeah, absolutely. So those are all essential, but they may not be unique to permanent supported housing or a vocational approach or substance abuse approach. But they're really absolutely essential. And there's a whole line of research called looking at the common factors in psychotherapies and in interventions, which are those things. They're essential, but not unique to that. Like a good therapeutic relationship is essential to the work we do. It's something we strive for, but it's not unique to any one practice. All right.
Interesting, Tom. The magic is looking like you are having coffee, but really gathering information and planning how to motivate change or identify strengths.
Nice. I like it. Yeah, and in fact, getting the coffee is likely building that therapeutic relationship, which is going to help the whole process work. So it seems like it's not necessary, but it really might be. These things are obviously not mutually exclusive, but they are kind of helpful to unpack the work we do. So what is it in the work you do? And I'm not sure if you're all from permanent supported housing or from different disciplines or interventions, but what is unique and essential to what you do?
Depression screening. Oh, interesting.
Yep.
The power to help people retain housing.
Yes.
The languages that we use, our language preference. You mean I'm wondering if that person means of their language or the way they use language,
or a little bit of both,
or a little bit of both. Yeah.
Their language of choice, right?
Right.
Now you can
confidentiality.
Yep.
Compliance reports. Okay.
Yep. And we can quibble about whether confidentiality is essential but not unique to your practice, but it is. I find this helpful in supervision to talk about what are these different levels, and can we unpack some of them. Now, if we were talking about more specific evidence-based practices, these would become clearer and clearer, of course. If you're doing cognitive behavioral interventions, you would likely have a thought record and a focus on cognition, on thinking, and how the thinking is affecting people's feelings and behavior. So let's move over here to this last thing, the prohibition. What is something that is prohibited in the work we do? I'll give you an easy one. Generally, it's prohibited to have a romantic relationship to someone you're working with.
There you go.
Yeah.
Dual relationships, personal relationships.
Don't borrow money. Probably you don't want to lend money. I worked for many years in a clubhouse. I don't know if people know what a clubhouse is, but it really blurred some of these prohibitions. I was actually the best man in one of the folks I worked with. They got married. I was the best man, and some folks would think that's a dual relationship, but that program was quite unique in that way.
And it should be noted though that these are not only are they individual as supervisors, but organizationally as well. If people are practicing different levels of friendliness or developing friendships, if they're the way they respond personally to people or the way they use language and communicate, that becomes confusing and difficult to maintain a standard, a practice that is acceptable.
Right. So this all harkens back to this idea of a reference standard. If we're doing supervision, the clearer we are about what's acceptable, what's expected, clearer the supervisory message can be. All right. So here are some examples, that I broke out for the different categories. You're going to get this PowerPoint slide. You're welcome to check it out. I mentioned this idea of the common factors. There's actually an interesting research on the idea that common factors may often be the thing that is curative and the thing that is that we keep measuring over and over. The American Psychological Association had a task force, and they tried to understand, why do all these different interventions seem to work despite being very, very different, and the proposed mechanism of action being very different. And it came out that there were these common factors. You see some of them here, that you have psychological contact between the counselor and the client. The client is incongruent, means they're anxious or depressed or vulnerable. Another term is ego dystonic, means they're kind of miserable, and that they're often open to helping, receiving help, and on and on. So this idea that we can often get good outcomes by focusing on the common factors, by that therapeutic relationship, by being there and being authentic with our clients. We can do better than that, but they called it, in fact, the Dodo bird verdict, meaning all must, this came from Alice in Wonderland, quoted this, where following a race, the Dodo bird said, everyone has won, all must have prizes. All therapeutic interventions work if you have the common factors, right? If you have good therapeutic relationships. A little overstated, but there's a lot of truth to that. Okay, so behaviors that are unique and essential to the model, we often call them the critical ingredients or the mechanism of action. So the way we maintain housing, the strategies we do that can serve as the mechanism of action, the critical things that we do to get good at what we're doing and achieve good outcomes. So I threw in this one last thing. Another way you can break this down is to separate the clinical interventions from more structural things. So sometimes if you're doing a program, you need the materials for the program, or you need the group space, or you need transportation, you need to get to there or get the person to you or whatever it is. So another way to break down, is it a clinical behavior, or is it more structural where you need some resource to make it happen? Okay, so Joe and I are quite familiar with this issue of competence over credentials. And it used to be much more common to defer to people with advanced degrees to do whatever they thought was appropriate. Joe calls this the private practice model. Now we see repeatedly that regardless of the person's credentials, it's what they do that can achieve good outcomes. And the term fidelity means if you do an evidence-based practice, and you make a good copy of that practice. In other words, you copy the critical ingredients well, that you often can see very good outcomes, regardless. You could be a peer, you could have a bachelor's level, a master's level. So that's really encouraging, frankly, right? Because we want as many people to get good outcomes as we possibly can. So this is a little tongue in cheek, but we'll see. Some people argue that, we don't really need clinical supervision to achieve clinical excellence. People come out of school and they learn a good deal. So let's just explore some of the science of this. If we're not going to use clinical supervision, what else is out there? This is actually really common, and we're doing this to you right now, as a matter of fact. And that is a train and pray, where I'll do a training in motivational interviewing for you, and then I'll pray that it changes your practice and that you have good outcomes going forward. Unfortunately, the science of this is, I think, I didn't even put the references, but there's so much evidence that trainings alone don't change clinical behavior. They just don't work that way. That you need supervision and what we'll be calling audit and feedback, something like that, where somebody watches you do it and gives you supportive feedback about how to do it better. It's like me trying to teach you to drive a golf ball by sitting here on Zoom. There's very little chance you're going to be a better golfer after my set. I don't even know how to golf, so there's that. All right, so trainings alone are not the way to go. That we need more than that. Option number 2, administrative supervision, and this is pretty common, where we just tell folks what to do. What we find here is that telling somebody to do a complex clinical intervention has very little impact on their ability to do the clinical intervention. And so another term for this is transactional leadership or transactional supervision, where we're just going to try to instruct people on what to do and those kind of behaviors. There's a term called stroke of the pen changes. So if this works if you're going to use a different form or do something in a different way, but it really doesn't work as we get more complex in terms of the work we're doing. One of my favorites, Chekov syndrome. Yes. So we think of the Chekov syndrome as a focus on outputs versus outcomes. So it's pretty common for community programs to count the number of groups that a person does or how many groups happen without really looking at the outcomes or the fidelity to the project or to the intervention. And here again, we see that outcomes aren't very good when that happens. If the focus is on outputs, the number of visits alone is not necessarily a good predictor. And that would be true in permanent supported housing. It's really not just the number of visits, but it's what that person described as, while you're having a cup of coffee, you're building a therapeutic relationship and you're thinking about how to help that person. So let me jump right now to just a little tidbit on the history of clinical supervision. And this comes from Carol Yedich. And she described this in England. She describes this woman, Beverly Allitt, who was accused of killing, I hate to bum you guys out, but killing quite a number of young folks in an institutional setting. And these folks had pretty significant developmental disabilities. And there was a committee developed, brought together to answer the question, how could this happen? How could this woman get away with killing all these young people? Where was the supervision, right? And unfortunately, it according to Carol Yedich, it led to this development of snoopervision, or I'm sure it existed before that, but at least in England, the focus became scrutiny over support. But Carol Yedich goes on to say that prior to that, clinical supervision, its earliest form was to support nurses in their very difficult work. They were often under the thumb of, they were often female and under the thumb of a medical doctor and under a lot of stress. And so she said that the whole idea was about supporting the people you're supervising. That was it. And then it took this nasty turn towards scrutiny and snoopervision. So one other aspect of clinical supervision I'm just going to throw at you because I'm kind of nerdy is you see these things called parallel models or isomorphic models in which, and it's often in the therapy domain, but like if if I'm working in a dialectical behavioral therapy, DBT approach, that I might use that approach in the supervision so that you would experience the intervention yourself. You see that with transactional analysis and maybe motivational interviewing, things like that. But it's a legitimate form of therapy. It's more common in psychology than in psychiatric rehabilitation. Although not necessarily. When I was supervising this program called Illness Management Recovery, everyone in the group identified a goal, which you do in the program, and sought about to pursue that goal. It was whatever they wanted, like people wanted to get a certificate or a advanced credential or something like that. And then, unfortunately, there is evidence of harmful clinical supervision, including this woman, Lovell, who did her dissertation on this subject. And in her research found that poor emotional bond and a poor ability to give feedback resulted in people feeling harmed, as well as dual relationships and role conflicts. So how about you? I'm curious, what have your experiences of clinical supervision been like? Any catastrophes? Any Joe Berkman, the guy you see in the video, has been my clinical supervisor for many years. And if anything, he suffers from a tyranny of niceness, which we'll get to, right? And I suffer from it as well, and he didn't cause it. But sometimes, so put in the chat what your experiences have been like, generally positive, negative, neutral, or you didn't have any. Yeah, but my background, so I often want to be liked over wanting to give good constructive feedback, and that hurts me in my ability as a supervisor and hurts my supervisees. Absolutely.
So we got so far 3 positives, 1 not bad, 2
dreadful.
Lack of guidance. It's a mixed bag.
Yeah.
And generally positive.
Nice. Well, hopefully, as we motor through this,
supportive in tone. I think, just before we go on, Tom, I think the other issue is that as you listen to these qualitative, you're not really clear what people want or should be looking for in clinical supervision, what supervisors should be kind of wanting to be like. So it becomes an issue of maybe sometimes not knowing what you want or what would work for you.
Yeah, you may not know what you're missing, actually.
Mm-hmm.
So I'm going to skip this just in the interest of time. We're about halfway. So this is one of my favorite parts of the presentation. The next few flat slides are actually slides. There's a green one. So there's a fella, this guy, Watson, and it's funny, I think his name is actually Watkins. I think I might have got that wrong. But he did a 15-year review of clinical supervision in the literature, and then just recently came out with a 20-year review. And he identified a gold standard. Other people have called this an acid test. And he says that if we're going to be doing clinical supervision and putting these resources in, it should be shown to improve client outcomes. And many people that responded to this article in the literature took issue with that. And I too take issue with that. And you'll see kind of why. So it's possible that even if it didn't improve clinical outcomes, it may improve the ethical treatment of the folks we work with, and it may improve the tenure. In other words, if people are leaving the job a lot through burnout and other things, it could be clinical supervision as part of the answer for that. So there are other possible outcomes beyond improved client outcomes, but you'll find that just now in the literature, you're starting to see the relationship of clinical supervision, good clinical supervision, to improved outcomes, and we'll kind of unpack that just a little bit. So this guy, Derik Milne, is probably the foremost researcher in the area of clinical supervision. And he just makes this point that there's kind of a nesting that occurs where somebody's trained in clinical supervision, then somebody supervises a supervisee, and then the last step is somebody provides clinical services to the client. And really, things can go bad at any step along the way. And so it makes the science of studying clinical supervision really pretty difficult. But as I mentioned, there really are a few people that have demonstrated this, this ability. So here's some of the nesting. So why do clinical supervision? This is my retort to Watson or Watkins, whatever his name is. And that is the research that we do know. So even if it's not improving client outcomes, it has been shown to increase staff satisfaction, reduce stress, promote accountability, including improved knowledge base. It's been shown to increase self-awareness, and you see the references there. Schoenwald is one of the people who did demonstrate the gold standard. Skill acquisition, improved knowledge and treatment, improve the supervisee-patient relationship. That sounds good. And been identified as essential to patient and practitioner safety. That was of course, in an inpatient setting. So it seems to me that one of the ways that we can demonstrate clinical supervision has this positive effect on clients is when we have really mature intervention. So the more mature the intervention is, when we're pretty sure if you do motivational interviewing in a particular way, very good chance you're going to get a positive outcome. And that's the point, by the way, of evidence-based practices, is that they can reliably produce dependably good results. But they have to be done in a particular way. You don't have to be Bill Miller or Sigmund Freud to get the good results, and you don't have to do it perfectly, but you have to be in the zone and at least understand the nature of the practice. What is the mechanism of action? Back to that triangle. What is at the top? And here's a couple of some of the more mature interventions that are out there. So here again, Derik Milne says I wish that was animated where SpongeBob his arms were going. But Milne says that many models of clinical supervision are impressively strong on imagination, but worryingly weak when subjected to careful examination. And I'm not sure if this slide is in here, but Borders in 1988 called for a moratorium on additional models of clinical supervision after only 50 models. And now there's just literally hundreds and hundreds. And that's a big problem, right? If we just keep making up new models and not testing anything, we're not going to advance the science of clinical supervision very far. And so here she is calling for a moratorium. Nobody listened, apparently, because you pick up any textbook and you'll find quite a few models. And it seems like every model has something, some little nugget. But what I'm going to be presenting today is a best practice synthesis. So a way of kind of not wading through hundreds of models or even 10 models, but instead looking at some of the common factors across clinical supervision. So Milne attempted to do this. He started doing this. I'm not going to belabor it. But he did an analysis of what was in the literature, and he found very, very similar commonalities, many things that you see in over and over and over, like listening. That's got to be good. And here there are 26 of them. We're not going to belabor them, but if you're interested, when you receive the PowerPoint, you're welcome. So here's his definition. This is Derik Milne's definition. And this really is where we start to get traction, I think. He says, clinical supervision is the formal provision by approved supervisors, and I approve of all of you, that's 72 people, they're all approved, of a relationship-based education and training that is work-focused and which manages, supports, develops, and evaluates the work of colleagues. So that's a mouthful. And this, of course, he's trying to operationalize it so we can study it. But he's got a lot of the bells and whistles there, I think. But he goes on to say, that's it, as though that wasn't bad enough. The main methods that supervisors use are corrective feedback of the supervisee's performance. We're going to be calling this audit and feedback. So auditing the performance and feeding it back. Teaching and collaborative goal setting, this is with the supervisee. It therefore differs from related activities such as mentoring and coaching by incorporating an evaluative component. So that's helpful. So it's not mentoring, it's not coaching because it has this evaluation part. And clinical supervision objectives are normative, which are quality control, restorative, which are encouraging emotional processing, and formative, which is maintaining and facilitating the supervisee's competencies and general effectiveness. All right, so that's a lot, and I apologize for putting you through that. But that's the kind of what he presented as the scientific definition. And here's what Joe and I are going to pitch to you, and that is that really, when you boil it down, if you can remember these three things, and they come from something called the Alliance model, or the Bridget Proctor was the first time Joe and I found these written like this. Now I want you to say these with me, and I'll know if you say it. Just say restorative, formative, and normative. And they must be true because they rhyme. And this is what we're going to spend the majority of the rest of our time together talking about, is these three functions, or you can call them objectives, of clinical supervision. Interestingly, Alfred Kadushin, 17 years earlier, came up with these three: administrative, educational, and supportive, which are the same three, but they don't rhyme. And so Alfred got ripped off by Bridget Proctor, and he should have too, because it's much better to have them rhyme. So let's say them one more time: restorative, formative, and normative. And we're going to,
Tom, you may even, when you thought before about reference standards in practice, these might be called the reference standards for supervision.
You are quite smart, my friend. Yes, and all that talk about the common factors. These are the common factors of good clinical supervision, and the reference standards. So if we're focused on these three objectives, and I know you don't really know what they are exactly, but maybe you can get a sense. But we're going to go through and just try and begin to define them right now. All right, so the restorative function, think of restore, it supports the emotional processing, reflection, and self-care, while supporting also personal and professional growth. In the literature, and you often hear it called reflective practice, or it's part of it, and it includes team building. So we have found this to be the special sauce, frankly, of clinical supervision, and it's the support function, right? It's the idea that we don't work with robots, that people we work with are not cogs, that they need support just the way our clients need support. And clinical supervision is the place for that, or a place for that. It's not the only place. And that the science of clinical supervision said this is a way we can build resilience against the stressors of our jobs, and they certainly are stressful. And this is one of the primary weapons against staff burnout, which we all need to be cautious about, because this work can be extremely stressful and taxing. So that's the restorative function. And we're going to actually, in part, the second hour, and we're going to take a break in between. But in the second hour, we're really going to unpack the restorative function. I'm going to give you some strategies and techniques and interventions for use to address this function, this objective. The next one is the formative function. And look, it's even in smaller font, so it's not as important. I didn't even know I did that. It's just done intuitively. All right, so the formative function, think of formative as forming new skills, forming new information. We use the term knowledge, skills, and attitudes to address this. What are we forming? We're forming new knowledge, new skills, and new attitudes. But these are where you see the clinical competencies, the motivational interviewing, the the technical stuff that we do and we learn to do. And we'll be, you practice some of this within the clinical supervision. If you go to a training, you want to follow it up with clinical supervision to stay focused on what you learned in that training. And that's how you take advantage of trainings, and that's how you make them not just train and pray. All right. And one of the things I don't think a lot of people talk about is the idea of shaping a culture, an organizational culture, but this is where we can do that. We can talk about what are the values of our organization, what are the values of our team. It can be really helpful. All right, so we got restorative, formative. Oh, can you check that? Yeah, a raised hand. Maybe that was just one finger on her hand. I'm not sure. It's possible. And I mentioned this idea of, the formative function is one of the gold standards of doing the formative function. If you can do it, it's hard. But it's called audit and feedback. And in this study by Ivers in 2014, he reviewed 141 randomized controlled studies on this approach called audit and feedback. And it was shown to have a positive measurable effect on clinical practice. So it's really terrific. And what it amounts to is auditing is watching somebody do a practice and then giving them feedback in a really supported way. It's not the scrutiny or the supervision.
Mm. And someone also mentioned the whole idea of you're doing great, which is not particularly helpful feedback.
Oh, right.
For most people, it's generally too general, if you will, to be particularly helpful.
Right. You can't act on it.
Right, exactly.
Yeah, I had a professor who he handed a paper back to me and he said, "This is horrible." That was the feedback. And he was right. But all right, we got the last function. So we got restorative, say I'm with me, restorative, formative, normative. And norm, you can think of the guy in Cheers, or what it actually means is the norms of our practice, the professional and organizational ethics and norms. And I've added this, Bridget Proctor didn't go this far, but I've added as the evidence that exists for effectiveness. So when you think of norms, if somebody's doing primal scream therapy as a way to maintain housing or to get a job, the person might be off base, right? I don't know that there's evidence for primal scream therapy in that way. So the normative function is the last one, and this is where the overlap with administrative supervision happens, because you need some norms. So the person, like I mentioned, the person has to show up. So there are administrative elements of this as well. Now, this should be a pro tip, actually, because this is really, really important. But one of the difficulties in being a clinical supervisor is in balancing this tension between the need for psychological safety for the people we supervise and the need to hold them accountable. And there's no simple way to resolve this, but we have to resolve this. It's got to feel safe for people to be willing to be vulnerable and take risks and learn new things. And it needs to be accountable, right? So we need to hold people accountable for excellent work and ethical work. So if you had asked me a couple of years ago, like, I might have said, yeah, these are the three elements of clinical supervision: formative, normative, restorative, or restorative, formative, normative. And I might have suggested they were all kind of equally important. I no longer believe that. Just the work I've been doing over the last year, the special sauce appears to be the restorative function, that if you get that right, people are willing to really take some risks and be more vulnerable within the supervisory experience. And we'll talk more about that. But so this is where I'm at. I might even bump it up even more. But you get the idea. So here's pro tip number 2. Well, I was right, it was a pro tip. If you can separate the restorative and formative functions, no, that's wrong. If you can separate the restorative and normative functions. In other words, if you can separate the support function from the accountability function to some degree, that could be really helpful. I apologize for the typo. And what do I mean by that? So when I do clinical supervision of a clinical practice, I am not their administrative supervisor. So I'm not yelling at them for coming in late. I'm not talking about their paperwork's late. I'm talking about the clinical behaviors that they're doing. So if you can do that, now, of course, I'm in a large organization. It may not be realistic in smaller agencies or smaller teams. All right, so I mentioned some pro tips. The first pro tip is try not to belabor administrative issues in clinical supervision if you can. Try to bump them up to your leadership if you can do that. The second pro tip is separate the support function from the accountability function, from the normative function, if you can, and to whatever degree you can. You'll never be 100%.
But you know what, Tom, as a supervisor, there's something to being vulnerable and accepting that you don't know everything, but being able to recognize what your skills and what your strengths are. Also being able to say, I don't know, or let's look at this together, or giving examples from your own kind of practice that kind of wasn't necessarily, or that reflected a need to get help. That also adds to the safety of people being willing to bring examples of practice that didn't go very well, or may not have gone very well, to actually have it scrutinized and looked at, and being seen as rather than a corrective experience, a learning experience.
Yeah, well put. And actually, we're going to be unpacking the restorative function in part 2 of today's presentation. We are going to take a break just to, very quickly, actually. So let's just review the objectives for this first topic. So the idea of being able to name 3 reference standards of a practice. So if you go back to the triangle, what would be 3 things that you'd want your supervisees to do, or similarly not do? What are the prohibited aspects? So I encourage you to think of that triangle, and I'll even send it. And it might be something you want to do in clinical supervision. Just have this discussion, like, what are the boundaries? What are the necessary and essential type of behaviors? So the second objective was to be able to name the 3 generic functions of clinical supervision. Let's just repeat them, shall we? Restorative, formative, and normative. Yes.
And Tom, either before we quit this, before we take a break, or after, one of the panelists had a very interesting take on it.
Yeah.
And she said, can't the normative actually be very supportive, allowing for vulnerability and discussing some of the challenges and getting into empowerment and solution focus, which is supporting them in their work?
Boy, I think that person should be presenting, because that sounds great to me.
Yeah.
Yeah, and I think, that challenge of resolving the tension between accountability and psychological safety, I think that person, it sounds like they've really given that some thought. So yeah, that sounds dead on to me.
Oftentimes, though, people don't. And that's probably, I think it's a great thing to aspire to. But oftentimes people tend to look very matter-of-factly at the normative. But you're absolutely right. It should be built in, and you can have some restorative qualities or you can in the normative.
Right. Yeah, they're not mutually exclusive by any means.
Yeah.
All right. So let's. What time we got here? Let's take a few minutes. We're going to come back at 5 o'clock my time, which is 4 or 3. Is that 2 o'clock? Yep. Yep. So just take a few minutes, grab a drink, use the facilities. Here are the microscopic references. I'll read these to you when you get. No, I won't. And when you come back, we're going to unpack the restorative function. And this is the best part of the whole series. So don't miss this one. All right, so we'll see you back in just a bit on the hour. Hey, Joe, are you seeing topic 2?
Yes,
Okay, great.
I got it. Actually, I'm just looking, I'm getting some numbers on the comments on supervision, how many were actually positive, how many were negative.
Joe, it's saying that my screen sharing is paused. Are you still seeing it?
Yeah, I'm still seeing it.
It's advancing?
No, it's not advancing. You try to advance it on your end, and let's see.
Yeah, it's not.
No, it's not advancing.
All right. Ow, I'm gonna figure this out.
Go back to slideshow.
Yeah, it's a little tough because I have too many screens. There's a problem with having too many screens. How about now? Are you seeing it now, Joe?
Yes, but now it's in that initial mode. So I think you have to, if you go back to slideshow, that should get it. That should get it back.
How about now?
Now we're going. Now we're black screen.
Oh, Jesus. All right. I'm going to crack this code, even if it means I can't go to the bathroom.
There we go. There you go.
Okay, thank God. All right.
So someone's, you mentioned it, but someone asked about the availability of slides, but you already covered that. Interesting. 60% of the responses were negative, 30% of the responses were positive, and 10% were mixed bag.
For clinical supervision. All right, let's get started. We're going to pick up where we left off at topic number 2. And I got to say, you guys are the best crowd I've had all day. This is by far the best attendees. Of course, I haven't done anything else today, but so. All right, so now we're going to talk about the first function, or the restorative function of clinical supervision. And it was interesting, I was thinking about what that person wrote about, can't the normative function be done in a supportive way? And I think that person is absolutely right. And when I think about it, just like all kind of therapeutic interventions, you want to be done in the medium of a therapeutic relationship, of a good therapeutic relationship. I think the same is true for the restorative, that all of clinical supervision should have this, be in the medium of restorative supervision. So yeah, that was a good insight. All right, so the objectives for this part 2, we're going to talk about restorative supervision and burnout prevention. And we're going to look at more than 2, but hopefully you take 2 away. 2 particular interventions you can use in clinical supervision. I do most of my work in group supervision, but I think some of this is applicable to individual supervision as well. And then we're going to look at this idea of reflective practice. Some people call it mindfulness, or there's an overlap. Understand the relationship of reflective practice and the restorative function. This is the sweet spot. This is good stuff. I'm going to get rid of me. Let's see me. So just as an exercise, list one if you would, even if you want to, list one self-care strategy that helps you at work. What's something that you do that you find restorative and helpful, other than leaving work? So let me know what's a self-care strategy that helps you at work?
No, lunch break. Take a walk around the building.
Nice.
Stepping outside for fresh air.
Nice.
Engaging in banter with coworkers.
Yeah.
Teaching yoga. So not only doing yoga, but teaching yoga.
See, that's awesome. If you can do something that you benefit from and other people benefit, that's great.
Sure. Taking a break. Put on some meditation music. Yeah, Led Zeppelin. All right. Walking around in the office and checking in with staff. Quiet prayer and listening. Getting away from the computer for 10 minutes. Taking breaks from the computer. Yeah, a lot of these kind of pauses, these reflective pauses,
yep,
Opportunities for meditation and for connecting with people seem to be coming up. I think the importance of connecting is
Yeah. So taking a pause and connecting.
yeah.
You know, it's interesting. I've met a lot of people in this field who don't pee. They don't drink water. In other words, they're so immersed in what they think they need to do that they really don't take care of themselves. So that's good to hear.
Yeah. Someone also mentioned a really important one, which is this balance, this life-work balance.
Yeah. Oh, yeah. We're going to talk about that in a couple minutes, actually.
Yeah. So
let's look at exercise number 2. What's a self-care strategy that helps you at home? Because this is the life-work balance, right? It's, you know, we can't just take care of ourselves at work. What are some of the things that work to be let you be able to do the kind of work you do? How do you take care of yourself at home?
naps. Right off the Bill playbook. Playing, baths, exercise, paying attention to loved ones.
What was the first one, Joe? Math book playing? What?
Naps.
Naps. Nice.
Taking naps. Yeah.
Yeah.
Sleep hygiene, getting good night's sleep, fun and relaxing activities, putting work out of putting the laptop away. Boy, you know, now that we have laptops and virtual phones and I'd rather cell phones and all kinds of virtual ways of getting together, we're never free, it seems, from work. So we have to really formally decide this is what we're going to do and actively do it. Visual art, milkshakes, that would work for me. Mindfulness, playing with the kids and playing with the dogs. Nice.
I just started a 1,000-piece puzzle yesterday. It's something my family and I do. That's great. So we're gonna fold this in, of course, into clinical supervision. But if you recall, and I can't imagine you would have forgotten in their short break, but we're really pushing the idea of these 3 functions of clinical supervision: restorative, formative, and normative. And that tension that we mentioned, and I thought that was a very interesting insight that person had, that one of the difficulties in clinical supervision. So let's just review. Restorative function supports emotional processing and reflection, as well as addressing issues of self-care. And this is a big weapon against burnout, and we're going to unpack burnout just a little bit. But first, let's just talk about this idea of people who do physical labor versus people who do emotional labor. And I'm arguing that you guys largely do emotional labor. Of course, there are elements of physicality as well. And so with physical labor, it can be really obvious what the dangers are. So you see this one guy, if you have a screen, one guy with a chainsaw, it's pretty close to his foot. I'm sure you guys in Washington cut a lot more wood than we do in New Jersey, but and you can also note that he's got all kinds of protective device: hearing protection, hard hat, orange shirt, looks like chaps, maybe a kind of leather chaps. And then to the right, you see these 2 fellas walking on a beam. And frankly, I don't think any of their protective devices are going to work for them should a big gust of wind come. But so you can see the dangers in just these 2 photographs. And it's my contention that organizations have a duty to protect their workers. That's true in slaughterhouses and for lumberjacks and for construction workers. And the federal government has agreed, and you've heard of the OSHA standards and things like that. So if we're doing emotional labor, which I defined as emotions sold for a wage, what are those? What are the dangers of emotional labor? Right? In a similar way, we can't always see them as clearly as we can in the 2 photos. I'll tell you a little bit about this idea of emotional labor. I was preparing for my dissertation, and I stumbled across this idea of emotional labor. And they described retail, right? You go up and the person's not allowed to be like, you effing, you just can't do that, right? You're expected to be in a particular emotional place and be responsive to the person you're dealing with, even if they're being rude to you, right? And that's true of the steward and stewardess. But it's true in a lot of professions where part of the reason you're hired is to maintain a certain emotional stance. It's even way more so in psychotherapy and in mental health. You're just not allowed to scream at anyone, or unlike the guy with the chainsaw who could be screaming as we were looking at his picture. We don't know.
And a couple of panelists described it as burnout and compassion fatigue and early onset cynicism. I love that.
Nice. Well, here's what I got. I got high stress, doing too much, vicarious trauma, compassion fatigue, burnout, poverty. Nobody mentioned poverty, I bet. For whatever reason, emotional labor doesn't seem to pay well, you know? But yeah, I think you guys are dead on. The doing too much part, you know, I was impressed by the ways people take care of themselves at work, but just as commonly, maybe more commonly, people describe not taking care of themselves, right? That they see their job, like the demands of their job are so high, or the needs of their clients are so great that they end up doing too much.
You know, and in some ways, even though this is emotional labor, there can be physical manifestations as well.
My God, yeah.
Stress kills, right?
Yeah, it's funny you say that. I did a conference presentation. I was actually the keynote. I'm not bragging, but I was the keynote, where I presented this thing called FIDWIS, which I made up, which was fix your damn workstation. For people like Joe and I, we sit all day as academics, and particularly now on Zoom, we're sitting all day. And if your workstation's a mess, you're going to have lower back pain, you're going to have shoulder pain, you're going to, and you may even carry your tension there. So yeah, really good point. That these all can have physical consequences. So let's talk particularly about burnout, because it really serves as a kind of a good umbrella for a lot of what can happen to people in mental health and emotional labor. And I'm going to use Christina Maslach's definition. And she said that burnout is a reaction to prolonged or chronic job stress. So we often use the term burnout, like, oh, I'm so burned out with toast, or I'm so burned out with some TV show or something, but that's not really what she's referring to. She's talking about a syndrome, and the syndrome has 3 dimensions. The first one is emotional exhaustion, where you wake up feeling tired and you're just like, ugh, I really can't take much more. And it may manifest as physical exhaustion, but it really is coming from an emotional place where you're just emotionally overwhelmed. And this happens, you know, for a prolonged period of time. Then, according to Dr. Maslach, the person will start to depersonalize those around them that are making demands. So in our case, it would be our clients. And she used to call this cynicism, exactly what the person in the chat said. And so as we depersonalize those around us, is in an effort to protect ourselves from further emotional withdrawal, we start to feel a reduced sense of professional ability or success. And that's the trifecta of burnout. What's really interesting about this syndrome is it's horrible, right? It's not a small thing. It's not something to laugh at, but it has real measurable consequences, and it happens to quite a few people, unfortunately. And maybe some of the people, our co-workers, are experiencing this as we speak. But my research, I found that there's 2 large studies in Europe where they found people that are suffering burnout, self-reported. I mean, they're saying, you know, they're feeling this way, experienced increased verbal and physical assault after experiencing this burnout. So it's, in other words, they're not feeling burnout because they were assaulted. They were assaulted because they're feeling burnt out. And it could be that depersonalization is not appreciated by clients, right? You also see reduced quality of professional work, reduced satisfaction, breaches in ethical conduct, lower productivity, increased in physical and mental health related problems, including drug and alcohol use, marital problems, right? So you see this global effect of burnout on a person's life. So it's not limited to their workplace, unfortunately. You also see a negative contagion impact on colleagues. I work in a state psychiatric hospital, so you just see that some folks are really, really negative. And we've done a bunch of studies on this, and we found something called the golden handcuffs, which I think comes up later, in which it's too expensive for people to leave. They have their pension and they're just waiting on their pension, but they're miserable, and they are in fact a contagion for their colleagues. And they don't intend it, they're suffering, right? But it's a big problem. I already mentioned a negative spillover effect on home life. And all of this is measurable and has been measured. Been quite a few thousands of studies on the effects of burnout. It's a serious problem. So I mentioned that we've done studies within the psychiatric hospital, and we looked at issues of morale, performance, mental and physical health, organizational commitment and retention. Also civility, we looked at perceptions of civility by people's coworkers. So some of the resources you're going to get, if you're interested in measuring anything, these are quite well utilized and normed, often normed for use in mental health. And I gave you a cheat sheet that will show you more details. And when you have my email, which is on the first page of these presentations, if you're interested in any of this, you feel free to reach out to me. I've done it quite a few times. So we did a very large study, over 1,000 people, clinical and support staff. And we found 22% of the clinical staff and 34% of the support staff are like housekeeping and food service and maintenance, things like that, reported high levels of emotional exhaustion. And so it's all around us, right? So 22% of nearly a quarter of the clinical staff in these institutions are suffering from at least the beginnings of burnout. And here's one of the things that's really interesting. So EE is emotional exhaustion. It's that one dimension that seems to start the whole thing. And if you're wonky like me, these are, the R is a correlation. And what's fascinating is you see high correlations between emotional exhaustion and other bad stuff, right? Depersonalization of clients is 0.598. That's a large correlation and significant at 0.01, right? And so you see reduced perception of organizational support. So when people are feeling emotionally exhausted, they don't feel supported, kind of makes sense. They're thinking about leaving, withdrawal cognitions, thinking about leaving the organization, lower career commitment, and perceived workplace instability. So high emotional exhaustion is just correlated with all of these negative outcomes. And so you could literally just measure burnout and high EE, or look for emotional exhaustion without doing the other scales even to some degree. So I already mentioned golden handcuffs. This is less true in community organizations because they tend to have less rich benefits. But in the civil service and state psychiatric hospitals, that's a big problem. That people really should leave for their own health, much less the health of people around them. Okay, so my mother used to say that Odette Bartholomew was my mother. She passed, but she said this quite a bit. And interestingly, her father was a plumber, my grandfather. And I'm going somewhere with this, I really am. But what I love about this picture is that dude is like, he's struggling with a pipe that seemed to have burst or something's going on, right? But look carefully between his arms. I think you see another arm of somebody who's in there trying to, I don't know if he's trying to help out or he got knocked over or whatever, but pretty crazy. So the reason I showed that and quote my mother is the idea that mental health workers, despite knowing a lot about mental health and often knowing how to help other people, don't always help themselves or aren't capable of helping themselves. And So this is an important area to go, right, in terms of clinical supervision. There's something called the Karasek model, which I used to talk a lot about, but because there's so much to talk about, I took it out. But Robert Karasek talked about our jobs, and he had a model called job demand control support. Demand control support. And he said, as our demands go up, if we don't have sufficient control and sufficient support, we will suffer burnout and physical problems. And he looked at industry, but he also looked at mental health. And in industry, you see cardiac problems, all kinds of physical problems, and early death. And in mental health, you see the same thing. You see all kinds of physical problems and emotional problems, as we were just describing. But that Karasek's model has been studied for 30 years. And there's these huge meta-analyses across the decades. And there's been this buffering hypothesis developed, which says that the negative effects of emotional labor can be reduced through organizational support. And this has been demonstrated repeatedly in the literature. So we can buffer those things that are harming our employees and ourselves. And so just very briefly, we're going to do, so think about a way to buffer. So obviously self-care activities are one strategy, and you don't need clinical supervision to do it. But if you were going to take on a new thing, what would it be, right? What new self-care activities, or maybe something that you want to restart that you used to do? So as I move ahead, just jot down in the chat, what are some things that you've been thinking about restarting, or you realize now you should restart? Because I'm having such a profound effect on you, right? That you're like, yeah, that dude's right. I got to take care of myself. So what do you think? Is anybody thinking about a new self-care activity?
Yeah, snail mail, reading, eating healthy, cooking, deprivation tanks, fishing. Hey, there it is.
Oh my God, that sounds
Staff
great.
potluck, walking when possible, personal training, exercise, always a great way to get the endorphins moving.
Oh yeah.
Personal training, hiking.
Well, probably a lot of these are going to restart after the weather improves, right? The spring is here, right? Started.
Water, the beach. Yeah, summer.
Lordy. So that sounds great. So this brings us to another fork in the road, which we kind of addressed a little bit, but this is the idea about the work-life balance. And we already did an exercise where we talked about work strategies for self-care, as well as personal strategies for self-care. And then people identified some possible new ones or things that are going to restart as the weather improves. But it begs the question, at least for me, what is the supervisor's role in staff resilience? What's the supervisor's role in burnout prevention? Obviously, we're not therapists. Well, we are therapists, many of us, but we're not therapists for our supervisees. And so the research isn't crystal clear on this, but it suggests that encouraging personal and professional self-care is a big deal. And it's something we should add to our quiver, our toolbox. And so some of the exercises we did today are that, right? Is getting people to think about it and strategize, what might work for them, what's realistic. Providing information on stress management, promoting support from others. So if we can use some team building and have collegial support, makes a huge difference. And then this last one, this idea of encouraging in open discussions about vulnerability. I know that's not written well, but you get the idea. Just encouraging people that if they choose to be a safe place to be vulnerable about what is actually going on with them. And these things are all demonstrated in the literature to have a positive effect on the well-being of people doing emotional labor.
And Tom, with all of us having been through a year of a pandemic,
damn, yeah,
it's really so critically important for supervisors to try to help people stay strong during these very stressful times. And really resilience and building resilience in people helps people to bounce back more effectively and to meet challenges more effectively because they have those connections, they have that support, they have that safety, and they're able, so therefore they're able to begin to work on those issues before they end up burnt out, which is much more, and it's much more difficult to address burnout than it is to address resiliency originally.
Yeah, such a good point. Although I can tell you, I read 2 large meta-analyses on burnout interventions, and both of them, or they're meta-analyses, so they're a compilation of a lot of different studies. And I left those, reading those, thinking, you know, really doing anything helps, right? Just being aware and attending to it. I used to think once somebody was burnt out, they're a goner, and there's probably some truth to that. But these 2 meta-analyses suggested that most efforts to support staff are well received and very, very helpful.
And consistency, I think, is the other critical element. The idea that as a supervisor, you are consistent across the lane with your support and your focus on resilience.
Yep.
So that's the other issue, is that people get comfortable with it and it becomes part and parcel of their work life.
Yep. Okay, so this is a pro tip. I never really even thought about this until I started doing this work. But that is this idea that vulnerability creates trust, and it's not necessarily the other way around. I would have thought that if I'm in a group that I feel that I can trust, I'd be more likely to be vulnerable. I'm sure there's some truth to that. But according to this line of research, when somebody in the group is vulnerable, others will more likely feel that they can trust that person and trust those other people in the group. It signals to the group that it's a safe place. And the reason I'm bringing this up is supervisors are often reluctant to talk about, you know, listen, I'm struggling during this COVID thing, and you know, I got plenty of issues myself. And of course, there's a limit to that, right? But modeling vulnerability, there's a lot to be said for it. And of course, as I mentioned, there's always limits to these things. You don't want to get your needs met through your supervisees, but you do want to model the fact that it's possible to be vulnerable in this group and talk about what's going on with yourself.
And it's interesting, you know, I was just reading an article, and people tend not to think of a Marine as being vulnerable, but part of the development of Marine leadership is to really look at and help people to be able to be vulnerable as they do their job working with troops. So it's interesting, even for the military.
So here are examples of things that I've used in my supervisory efforts. And the first one was just introduced to me a couple of weeks ago by a colleague, and I just absolutely love it. And so I'm just going to share that. I stole it from her, and I'm going to give it to you. So I think we have examples of all of these. So let's just move ahead here. So this comes from, I forget what Seligman's first name is, Dr. Seligman, but he was is the father of positive psychology. And positive psychology, unlike regular psychology, is focused on what makes us well, right? So historically, psychology has focused on illness and abnormality and problems. And I mean, it seems like an obvious thing to do, but he did it. And coming out of his camp here, and I think he's at the University of Philadelphia, is the PERMA model. And it stands for positive emotion, engagement, relationships, meaning, and accomplishments. And this is something you can use this model in group supervision, or you can do a presentation on it and get people thinking about it and talking about it. So what does it mean? So positive emotion, the question is, what leads you to have positive emotion? I encourage you to put in the chat if you like, what leads you to have positive emotion? Like, what are those things? If you were to scan your life and do a bit of an inventory, as I'm doing that myself, oddly, distance running, I've been a distance runner for years. And while sometimes the run itself isn't so great, the stopping running brings me positive emotion. So what brings you positive emotion?
Validation.
Nice.
Watching the antics of my turkeys. Oh, interesting.
Oh my God, that sounds great.
Thoughts of my daughter and the funny things she says. Laughter in family. Connecting with others. It sounds like people are a critical element of being positive is your relationship with others.
I can just imagine that person watching their turkeys and a big smile comes over their face. That's great.
Holding hope for someone when they can't.
Nice.
Good. Grandbabies, definitely. Yeah. Family and loved ones.
That's interesting. I thought of positive emotion as like joy and smiling and stuff, but I imagine you can have positive emotion. I wonder if meaning is one of the ones coming up. But yeah, that's terrific. So the idea of this exercise is to encourage people to reflect on what is it that brings this, causes this, and then do that, right? More of that, and be conscious about it and be planful. Right, as you know, because I think we have all had times where we've sat in negative emotion and felt kind of stuck there. The next one is engagement. And what things do you find that you most promote engagement in your life? The idea of you may have heard of this book called Flow, which is a study of engagement where people get lost in an activity. And I would tell you the guy's name, but I cannot pronounce it. He's a Russian author, I believe. If anyone can put that name in the chat, I will send you $5 because the name is virtually incomprehensible to me. I won't really do that. I was lying, by the way. So any thoughts? Anybody put in the chat, what do you find engaging? What kind of things suck you in? It doesn't have to be flow either, right? Puzzle building is very engaging for me in a silly way, but it's pretty great.
Interesting. Providing clinical supervision.
Nice.
Absolutely. Part of the engagement in PERMA has to do with the idea of what you're doing has meaning to it and is meaningful to yourself and others. So that's also I think really important. But going rock hunting, reading games, relationships, identifying childhood stories, Zoom meetings with my newfound birth siblings.
Oh,
wow, they've only known since Christmas. Oh, that is so cool.
Yeah.
Oh man. But yeah, but also at work, what do you do at work that and for your supervisees? How do you make sure that they have meaning as well?
Yeah, it's a really good point. I find myself when I'm writing a manuscript or I do a lot of manuals, treatment manuals, I just get lost in that. I kind of snap out of it after, a half hour or an hour and realize I was completely sucked in. So you get the idea. You talk about what relationships are most important, what brings you meaning, what are things that you feel accomplished? You feel a sense of accomplishment when you do it. Of course, my puzzle building, that would be one. Which one should we do, Joe? Let's do one more. How about accomplishments? What things do you feel like a greatest sense of accomplishment in doing? I tell you, for me, I'm 57 and I run 10 or 15 miles and that, at my crickety old age, that is a tremendous sense of accomplishment. I'm amazed every time I do it.
Learning to play the marimba.
Ooh. Nice. I don't even know what a marimba is. What's a marimba?
Marimba
I'll look it up.
Making sure my kids have a good day, being helpful,
Nice.
completing a home project and feeling fulfilled. It's an African keyed instrument. There you go.
Nice.
There you
Marimba.
go.
Well, I learn something new every day.
Watching the light bulb moment when you see someone you supervise get the concept you're teaching
Nice.
made out of wood. Mihaly Csikszentmihalyi. What the heck? It's a good thing that I'm not Eastern European, because I would really flunk out of school, because I have a very hard time.
Is that the guy's name? Who?
Yeah.
Oh my God. Oh my God. Yeah. I didn't even recognize it. That's how far off I am.
In accomplishments, it's not only kind of what you've accomplished, but it's also being able to set reasonable goals for yourself and accomplishing those goals.
That's right.
So it's also making sure you don't set yourself up for failure, but set yourself up for success by articulating goals that are achievable.
Yeah, I would encourage people, if this is kind of doing what it does for me and really getting me thinking, go to the PERMA website and just look up. You can just look up PERMA model or Seligman and you'll find it. Really, really good stuff. I just love it. All right. So I mentioned, just going through some of these exercises, and there's no right answer to what you should do to promote a restorative atmosphere in your clinical supervision, but these are just ideas and things that I've used and continue to use. This one is kind of a little different, but a chaos inventory was introduced to me by a colleague, and it was actually a scale called the chaos inventory, but I just use it as when you're under stress, how does it manifest in your life? What things do you see? And so, for example, I become super tidy and organized, like super ridiculously tidy and organized. Some people do the opposite. Some people eat more, they stop eating, or my colleague says that his car looks like a bomb went off in his car when he's under stress because it's the last thing he wants to deal with. So how about you guys? If you did a chaos inventory on yourself when you're under stress, what would you see manifesting as part of that stress?
Shut down.
Shut down, overeat.
Become a human instead of a human being, a human doing instead of a human being.
Oh my God, just going through the motions.
Adrenal fatigue. Overeating, paranoid about work performance.
It seems like we have
overreactive.
We have some experience with this.
Become quiet. Yeah, no sleeping well.
Right.
Yeah, I got about half a dozen of these I could probably claim myself.
Yeah, and that's when you're not under stress.
I know. I get short with people, imposter syndrome, leave things for tomorrow, fatigue.
Nice.
Grind my teeth. A whole bunch of So
that's another exercise called the chaos inventory, and use it if you think it's going to help. So mindfulness exercises. I learned these. I mentioned earlier dialectical behavioral therapy. Dialectical. I can't even say the word anymore. But it's Marcia Linehan's approach to working with folks with emotional dysregulation. And it's really based on Eastern philosophy to a large degree, and including mindfulness. And so we practice mindfulness in the supervisions. And we do mindful breathing and sitting and walking and stretching and eating. Sometimes somebody will bring in like a nut and we'll just eat it very slowly and try to be as mindful as possible, and then talk about the experience afterward. I added mindful pooping, and my wife freaked out at me, but I just think that's funny. And you can do mindful pooping. I don't see why you can't. So down here, this, Joe, can you put the website in the chat? No, oops. We have a website where we have a large number of mindfulness activities, as well as trainings in a large variety of things. And you're welcome, it's free. I know that's a really long website, and I don't know if Joe's up for cutting and pasting.
It's, you know what, it's actually on slide 34.
Oh, I didn't know that.
By the way, I just wanted to mention in terms of mindfulness,
Yeah.
that it really is a great way also of either before a supervisory session or during a supervisory session or in preparing for a supervisory session to kind of get yourself relaxed and ready to go, to kind of
Right.
move from what you were doing before to what you're going to be doing. It works really well as almost a kind of an ice-breaking kind of thing for you and the folks that you're working with. It kind of gives everybody a place to begin to be present for what they're doing and to leave what they were doing previously.
Yeah, absolutely. I do a thing every morning, a mindfulness practice, and often the exercises, I try to breathe in one, breathe out one, breathe in two, breathe out two. I try to get up to 10 and sometimes go backwards. And when I can get to like 2 and then I lose focus, I know I'm under some stress. So it's kind of taking my mindfulness pulse. Yeah.
And someone mentioned I do a quick mindfulness exercise to center myself prior to going into supervision. It allows me to come into the moment and be present with the person I'm working with.
Yeah, nice.
Absolutely.
So good. I don't think you guys need us. I think you're good to go. So there's a couple other exercises. They're pretty straightforward, like a self-care round. It's very common. We'll just be like, how's your self-care going? And if you want to make a commitment, a stretch, you can do that. Maybe I think that might even be coming up. So in the literature, there's something called reflective practice. I see a lot of overlaps with mindfulness. And a colleague of mine described something called a linking skill, which is oftentimes our clients, they have the skill, but they don't have the linking to when to use the skill. In other words, they know about deep breathing, they know about X, Y, and Z. And that mindfulness can be that opportunity to be like, yes, now I need to take care of my lower back, or now I need to do some deep breathing because I'm really feeling the stress. So that's one way that mindfulness can be restorative, is that it can link us to doing the things we know how to do when we choose to. Oh, gotta keep going. All right, so here's another one we do. Just having the group do a round if you're meeting in group supervision, and talk it from 0 to 10. How burnt out are you feeling? And if folks are, give you a very high number, you say, is this something you want to talk about? Is there any way we can help? A lot of times, people just having an opportunity to talk about it, right, helps, even if you don't have a concrete strategy that you're going to employ. And this may not be the syndrome of burnout, but be that the other type of burnout, like I'm burnout with toast, like you're feeling burnt out today. It's just an expression we use. The other restorative approach that we've used a good deal, particularly as we're getting started with a new supervisory group, is team building. And one of the exercises I've used a lot is having folks interview one another and introduce that person then to the larger group. And it's just been fascinating. We've had groups of staff at the psychiatric hospital that have been working together for years, and they reported as not knowing anything about the person other than what they see professionally, including hobbies. And, here are some of the questions, but you can really put any question you want. Very common after doing this exercise for people like, I didn't know you were interested in gardening. I'm interested in gardening. And you just see the burgeoning relationship. So, and it's not hard, right? It's really just a matter of just, going through, you feel a little awkward when you start doing some of these things, but the payoff can be really, really high. Oh, I mentioned this. So often we do a round of, self-care strategies. And then if a person, I went out to Washington, I was actually in Wenatchee, I can never say that. And I did a round like this with the mental health providers there. And they said, almost to the person, they said, yeah, I kind of stink at this. And so I encouraged them to make a stretch and say, is there something you'd commit to? And you can use this group as an accountability group because they tended to work with one another. And so a bunch of people made stretches to, to try something new to increase their self-care focus. So that's cool. I know we already did an exercise where you guys did some of that, talking about what's a new one you might add or something you want to restart. Yep. I know you're just laughing hysterically, even though I can't hear you. But these are my slides. So just go back and look at some of these pro tips. I think they're out of order, but the idea of, if possible, separating the restorative function from the normative function. And I do agree with that person who posted it. It's not that it's impossible to do it. It's just harder to read somebody the Riot Act about their documentation and then be like, how's it going? How's everything? How are you feeling? Pro tip number 2, vulnerability creates trust. It may not always be the other way around, the way we often think of it. And here's a bonus tip. And this is an interesting project I'm involved with right now. And that is that supervisors like yourself often get very little support. And so I've started a supervisory group for supervisors, and we call it meta supervision. But we focus on best practices in clinical supervision. So those are the reference standards, is best practices. But it's really high in the restorative function. And almost to the person, and myself included, it's one of the best professional experiences I've had or have. And what these supervisors tell me is that they're often squished between the leadership and their subordinates. And sometimes the leadership is telling them to do something dumb, and they kind of just have to try to make it work. And it can be really stressful to be squished in that way. So I encourage you, if you can meet with a group of supervisors, that would be great. If you need, find a professional organization in Washington that you can join, or even one that's national. It can make a huge difference. Supervisors can get very lonely very quickly, especially in small organizations. So that's the restorative function. Obviously, there's a lot of room for creativity. But I encourage you to think about how you might, I'm sure everybody's doing this to some degree, but how you might step it up, particularly during this global pandemic. And I think, at least in our system here in New Jersey, COVID has really shined a light on some of the deficits in our supervisory approach and our is kind of how we're seeing supervision. We realized we didn't have a formal way to support staff. People sought out support informally. And so this was an opportunity to rethink, how to build this into our supervisory efforts going forward. So we just have a few more minutes. Let me know in the chat, what are some of the ideas you might take away from me blathering on and for over an hour? What are some of the take-home messages, do you think? A lot of previous comments for this presentation have been that a lot of it's review, which I would anticipate if you've been a supervisor for a while. But any take-home messages or additional messages for us? I'm going to stop sharing, and I'm going to put our website in the chat because, as I mentioned, there's a large number of trainings available to you. Any take-home messages, Joe?
Let's see what we got.
To use PERMA. Yeah, I like it. Oops. All right, where is the chat?
Encourage clinicians reluctant to receive clinical supervision for their own restoration. And if you don't take care of yourself, it won't be good for others.
Got it.
Yeah, and it's interesting, clinical supervision is meant not only to, I think, from the organizational perspective, help to engender a positive experience in the organization. It also, the bottom line is clinical supervision increases the quality of your service delivery.
Yes.
So that is critically what you do. And so that whole resilience piece gets reinforced not only by you and then by your supervisors with patients, but from the organizational perspective as well. You might even call it organizational resilience. So it's really important, like I said, this whole idea of developing resilience and helping people to bounce back and supporting people is just so critical to the bottom line of connecting, whether it's connecting as a team, connecting as supervisors, supervisee, connecting as members, peers in a group, or even with the folks that people are providing services to.
Yeah, I'm just looking here. I'm just loving the chats. This person's saying, we're living through a trauma right now, and that we need to address it with ourselves, use perma or bits of it in each meeting. Self-care is a big issue. And now if you look in the chat, I hope you can cut and paste those, or maybe just click on it and go there. You can leave us. Develop and recognize your own warning signs. My supervisor group has scheduled a weekly hour-long check-in. Nice. It's incredibly supportive. We do the same thing here at Rutgers University. And yeah, it's made all the difference, frankly, for me. Great reminder of the importance of humor. Did not know they could be funny in New Jersey. What the hell's that supposed to mean?
You must have heard that from New York.
Yeah, right. Oh, I can't see the links in the chat. Oh, they went by too fast. All right. I'll keep doing it then. I don't know if there's any other way. I'll add the link to the materials I send out. So even
right,
if you
and they'll be on the Tom. They'll also be in the. They're on, like I said, on slide 34 in the slides that.
Right, and they should be clickable, so you don't have to type in that crazy long. Thank you, guys. So we're gonna wrap it up. Leave it there.
Stay well. Stay calm.
What's that?
Stay effective, guys.
Yeah, and good luck with your new self-care activities. You guys were the best group, I am telling you. I'm moving to Washington. New Jersey stinks.
The slide will be on this.
All right. Oh, geez. I didn't click. I was sending it to the wrong. Ugh. It's all right. That was my bad. That's what I need to do. I was sending it to just panelists.
Oh. I was gonna say, I got it a number of times.
Yeah, I'm sure you did.
I know it.
You should go to it. All right.
All right, good job.
Yeah.
That was fun.
That was fun. Back to the workshop. To the Batmobile.
All right.
Joe, I'll give you a call. Why don't we let's sign out.
Okay. Wenatchee is pronounced Wenatchee. Oh.
Boy.
Better get that for the next one.
You know, people told me that before, and I just can't keep it in my brain. Wenatchee. That's cool.